Session 2. Sexually Transmitted Infections and Mucosal Dermatology. Moderated by Dr. Tariq Ibrahim, Dr. Fatima Al-Breiki, Dr. Amal Al-Saberi. Session 2. Sexually Transmitted Infections and Mucosal Dermatology. Moderated by Dr. Tariq Ibrahim, Dr. Fatima Al-Breiki, Dr. Amal Al-Saberi. Session 2. Sexually Transmitted Infections and Mucosal Dermatology. Moderated by Dr. Tariq Ibrahim, Dr. Fatima Al-Breiki, Dr. Amal Al-Saberi.
Assalamu alaikum. It's my pleasure to introduce Dr. Nicolas Toupin. Dr. Nicolas will speak about how do I approach genital ulcers. Welcome, Dr. Nicolas.
Thank you very much, Mr. Chairman. And I just want to thank the organizer of the 5th Radv meeting for inviting me in Dubai and for talking about STI. I thank them to dedicating one session to the STI. I think it's very important that dermatologists always think about STI when they are looking after patients. So I'm coming from Paris. I'm the head of department of the dermatology department. I have also a STD clinic in Paris. So first of all, the main message here is that in front of GU, you always have to evocate it systematically STD, STI, with the main etiology, the rare infectious causes, and when you have eliminated infectious causes, you have to think other disease. Here is a paper published several years ago about the causes of GU in a STD clinic in Paris, France, in Saint-Louis Hospital. And as you can see here, that in the total of 278 patients, the first cause was primary syphilis, with about 35% of all causes by primary syphilis, and herpes, genital herpes, was the second cause, as you see here. However, the cause depends on the gender and the sexual orientation. If you look at women, and if you look at men having sex with women, you see that genital herpes is the first cause. In fact, there is an overrepresentation in this cohort of MSM, and in MSM, the first cause of genital ulcer was primary syphilis. Another message which is, I think, very important is that the clinical examination, the sensitivity and the predictive value of clinical examination is poor, in fact. And in this old study from DiCarlo, you can see that 20% of primary syphilis and 35% of genital herpes met the 3 criteria of more than 3 ulcerations, pain, and superficial. So, how I manage patients with genital ulceration? I think we have some laboratory exams to be performed systematically. I always do a direct examination of the ulceration. I always perform DFE and Zhang cytodiagnosis and sometimes Gram or blue strain. I always perform a blood test with syphilis serology, which is mandatory, with both TT, RPR, VDRL, and ELISA, TNT, sorry, TNT is RPR. I always perform HIV test, and I always ask for HIV viremia, because you know that in some patients, during early stage of HIV, the serology could be negative. And if you are rich enough, you can perform the molecular biology test, PCR and AAT. You can do them for TP, HSV, and it depends on the population. Then in MSM, I would suggest to perform HD, Haemophilus ducreyi, monkeypox, and chlamydia trachomatis. Of course, an important message is you don't need to do HCV and HSV and chlamydia trachomatis serology. What are the causes of genital ulceration? Syphilis, of course, should be systematically suspected because there is a recurrence of this disease, because it's easy to treat. It's a high prevalence in MSM. There is a high proportion of HIV-infected disease, and there is a high percentage of association with other STI. This is some example of chancre. The typical chancre is painless, and is proper with a nice border, indurated border, as is in this case. But you can see you can have inflammation, you can have both chancres, you can have inflammation also. So the clinical examination should be done, of course, but don't worry. Sometimes the clinical presentation is not typically for syphilis. Another thing which is very important, when you will see patients with primary syphilis with a chancre, maybe the serology will not help you. This is a nice piece of work. We have performed this, we have done with a dark field. You have ulceration positive by dark fields. That you know that CDC definition of primary syphilis included a positive dark field exam. So we know this case were really syphilis. And as you can see, we have nearly 50% of the participants, of the persons with primary syphilis, they have a positive test for TT and TNT. However, nearly 20% are both tests negative. That's why PCR now should be performed. In France, PCR is not reimbursed. And you perform the PCR, but it's not at the nomenclature. I'm fighting to have this test for the nomenclature. You can see the test is very good in sensitivity for primary and secondary syphilis, and the specificity is high. And we have also performed a study on ulceration which are positive by PCR, which are primary syphilis. And you can see here that nearly 40% of patients with primary syphilis have a negative TT and a negative TNT during primary syphilis, but the PCR was positive. Two examples. One with the Folman balanitis. The patient was negative by TT and TNT, but the PCR was positive. And the other one is a patient with multiple chancres. We thought maybe it could be herpes, but it was not painful. So we performed the serology. It was negative for TT and TNT, but the PCR, again, was positive. So in summary, all syphilis exams may be negative in primary syphilis. So a high proportion of patients will not attend a second visit. Primary syphilis chancres will disappear spontaneously in a few days. So we recommend to perform systematic treatment of 2.4 million unit BPG intramuscularly is required in all cases of GOED, except if you have the notion that it could be genital herpes. Why? Because genital herpes, you have vesicles. You can see also erosions and ulceration during secondary syphilis. But of course, both TT and TNT are positive, and sometimes you can help with PCR. Genital herpes is probably the most frequent etiology of genital ulceration. Both HSV2 and 1 can lead to ulceration, genital ulceration. And in European countries, HSV1 is the most prevalent cause of primary herpes, genital herpes. Of course, you have the classical vesicles that can lead to polycyclic erosions. And during primary infection, you will have edema and pain. The PCR will help to perform the diagnosis, to confirm the diagnosis, and sometimes patients need to be hospitalized to get acyclovir, intravenously acyclovir. The clinic is difficult. Just a little test, a quiz. There is one herpes and one syphilis. I will show you. I never remember where is the herpes, where is the syphilis. This is the case here. You have a little erosion. This is exactly the same. In fact, you have syphilis on the right and herpes on the left. Other causes. A story, short story. 45-year-old, he was hospitalized in a hematology department for treatment of a rectal lymphoma. Diagnosis on a biopsy of the rectum. He has no other localization, and bone marrow biopsy was negative. He just has to have his chemotherapy the day after. We were contacted because the serology, syphilis serology was positive. When we looked for the patient, he said that he had syphilis in the past, but the TNT decreased regularly since he was treated. He said that he has diarrhea since 2 months, and the diagnosis of rectal lymphoma was performed. You proceed to the examination of the patient, and the patient said, "Oh, you are the first to examine me." So what we see? We see just a little ulceration on the anus, on the perianal anus area. What do you think it is? What exam should you perform? No answer? you must perform a PCR for chlamydia trachomatis because this patient has no lymphoma. You save his life. You save his life from having chemotherapy. He has lymphogranuloma venereum, of course. You save the life of this patient. Other cases you can see with lymphadenopathitis. 5 minutes left, thank you. And it's always STDs, they can mimic everything. And I have another patient, he has this ulceration of the colon, and he was supposed to have Crohn's disease, but in fact, he has a lymphogranuloma venereum. Differential diagnosis, chancroid, we don't see any more in Europe, but we can see them from patients from Africa, South America, and this is characterized by multiple ulcers, which are common, and the treatment is based on azithromycin. Inguinal granuloma, also, we don't see any more in Europe, but you can see them from patients from Southeast Asia, Africa, New Guinea, South America. Ulcer is not painful. Localization is on the pubis perigenital, not the mucosa. And treatment is also based on azithromycin, erythromycin, or aminosid. Another story, very quick story, a patient who called me because he has an ulceration since some days now with fever. He has genital herpes, genital condyloma, and no other background. What do you think? He spent some time in 2022 in Spain. He has sexual relation with men. As is monkeypox infection, I will not go. I will go very through because there is a talk on monkeypox. Very few. Another cases of very rare cause of genital ulceration, skin ulceration, and lip ulceration. What it is 2 minutes left. Okay, so this is primary HIV infection. This is the kissing ulcer. This is in prepubertal woman, very young woman, with kissing ulcer, ulcer en miroir, mirror ulcer. What do you think it is? It is lip shoots, and it is associated with viral infection, especially EBV. Hafter, which can be isolated, associated with Behçet disease or other inflammatory bowel disease. A patient treated by doxycycline, you make the diagnosis very easily because it's appears 2 days after taking the doxycycline. It's fixed drug eruption. An erosion with leukokeratosic lesion, and you always look for the mouth, and you see that there is a lichen planus. And of course, epidermoid carcinoma should be evocated in this patient with chronic ulceration. So take-home message, ask the good question. Always think that the index of performance of clinical examinations is low. Always think that it is an STD. Always think that a good is a syphilis. You must perform dark field PCR, syphilis serology, and HIV viremian serology, except if there is vesicule, treat it a primary syphilis. Think about other causes after seeking STDs, after fixed drug eruption. In case of subchronic, chronic, or difficult to date GU, always think about carcinoma. What are the good questions in practice? Did you have sexual risk? All GU. Have you started a new treatment? FDA. Have you applied something on your genital area for caustic irritation? If so, since how long you have the GU, important for dermatological causes, especially epidermoid carcinoma. Was it your first time? Recurrence is in favor of herpes, Hafter. Did you experience such during the past? Have you suffered from oral Hafter? So for Behçet disease, for example. Have you suffered from intestinal symptoms for Crohn, but not always? Sometimes it can be LGV. And just my final slide, I always think about what I have to do for GU in considering, is it the first episode? Is it a recurrence or a relapse? Is it a chronic ulceration? And you will act in function of this chronologic appearance. Thank you very much for your attention.
Thank you, Dr. Nicolas, for the nice presentation. Any question for Dr. Nicolas? In the application? Okay. Thank you, Dr.
Thank you.
Thank you.
We'll move to the next talk by Dr. Jahirsha Bakran. Dr. Jahirsha Bakran is going to talk about monkeypox experience in United Arab Emirates.
Assalamu alaikum, everybody. After the excellent talk by Professor Dupin, we will move away from the classic STDs towards the non-classical ones. The new kid on the block that mutates not in millennia or decades, but in years. This is a quote by Charles Darwin that those who adapt, they'll be the winners. Mpox is a pox viridae that shares about 90% of their genes with other poxvirus like smallpox and vaccinia. But where is the monkey in the monkeypox? There's something known as a Copenhagen mistake. When they imported some animals for studies to Denmark, they found a new pox virus, and it being discovered in monkeys, they called it, of course, monkeypox. But later, throughout the years, they found it is endemic in Africa. Like we divide history into AD and BCE, what you can do with Mpox is the things that happened before 2022 and after 2022. You will see that before it was a zoonotic infection and it was endemic or exported from animals. After 2022, we all started seeing the disease worldwide. So the original reservoir of the infection is in fact not monkeys who are accidental hosts, but small rodents in Africa. And you can see that the transmission was acquired through mutations to go from one human to another, either by sexual route or through close contact and droplet infection. Rare means of transmission has been vertical transmission during birth, as well as through sewage system. The structure of Mpox is very sturdy, which means that it stays in the environment and there's a high chance for spread through fomites in households. So as for the pathogenesis, in short, you will see that initially a wound, either during a sexual encounter or close encounter, the virus is inoculated in the skin and taken up by macrophages. Similarly, through the respiratory tract, but to a less degree, goes to the lymph nodes where there's an immune activation, and at that stage you get the lymphadenopathy, followed by viremia, fever, and seeding in all organs, resulting in headaches, gastroenteritis, urethritis-like symptoms, and oral ulcers that can, while talking in close contact, lead to the spread to other close contacts like family, children, but mostly through the sexual fluids like semen and vaginal fluid, and through contact with the lesions. And like all other pox viruses, they go through the stages of macule, papule, papulovesicle, papillopustule, crusting, and healing in 7 to 14 days. One clue that is very useful for us, because we get lots of cases in the emergencies asking them about the smoke ring sign. This means just look for those annular pustule either with a red or black center, and it usually helps us even without a test. We have heard a lot about clades, so what are they? You can say they are cousins through a common grandmother or common ancestor. It's the easiest way to understand. Throughout the history of Mpox, and after the smallpox vaccination started to wane, and there was a re-emergence, what they found is that there are some diseases more severe and some are less severe. So the one is number 1 in severity, and the clade 2 is less severe. As well, some got the mutation to transmit between the humans. So the one that remained endemic in Africa, and it is a zoonotic infection, became 1A and 2A. And the ones that we see in UAE and throughout the world are the Bs. To become global, it's easier to understand. And we'll be talking mainly about 2B. So 1A is mainly in Africa. It's a zoonotic infection, mainly among kids. And 1 has more mortality rates than the 2A. And this case is from 1986, and the other one is in 2024. There's not much change in that clinical presentation. Looks like smallpox and high mortality. So the 1B and 2B that we will be seeing in our cases, they are global. And there's human-to-human spread in adults, sexually active adults, through sexual spread, but there is high survival rates. So clade 2B cases have localized lesions, up to 10 to 20 lesions in most of the cases with lymphadenopathy, and they are most severe in HIV cases. The new one, since 2 years, we are getting case of 1B. So the lesions seem to be similar to the 2B we saw earlier, and there can be just genital or generalized lesions. So to compare it, in smallpox, we have centrifugal lesions, and 1A, the severe form, has similar features to smallpox, whereas the sexually spread 2B has features of localized lesion, especially in the genitalia, lower abdomen, etc. And the new clade 1B has features in between both. So what's happening in the Middle East? As I told you, we have 1B, 2B, but also some imported cases of 2A. So this was our publication, and you can see mainly young sexually active adults were affected. Incubation period of around 7 days, but somewhere up to 21 days. So if your patients come late presentation, this can also happen. And barrier contraception was not protective because other fluids are also infectious. Our cases were mainly heterosexual, unlike the UK experience where it was mainly a homosexual exposure that led to mpox. The sex workers were the means of contact in most of our cases. There was fever in 75% that lasted around 4 days. It was mild or moderate. And the lesions were mainly on the lower part of the body. New lesions occurred for around 1 week, and they had urethritis-like symptoms, but by testing, it was negative for other STDs. Lymphadenopathy was noted as well, and these are the lesions on the face. Some were furuncle-like lesions. Some had really profound edema. Lesions on the lips. This patient had a lesion on the lower eyelid associated with episcleritis. You have to look for the lesions on the scalp if you need to find them, on the trunk, upper limb, lower limbs. It looks like insect bite reaction or folliculitis. On the hands and feet, the lesions were more deeper and either crusted necrotic lesions or deep-seated gray pustules. On the groin, it could be just a few lesions to hundreds of lesions, like in this case. Initially, they are like papillovesicles. They progress over days to these necrotic pustules, and some had a syphilis-like presentation, some had herpes-like presentation, some had phimosis. In the female cases, again, there is a spectrum from few to numerous lesions that coalesce, and they heal with scabbing that falls off. So these are the more recent cases, and we don't see any difference in presentation with the new clade introduced to our region. Only complications we saw were in HIV cases where they had an exaggerated form. The pustules were larger, forming rings, and this patient actually died from the disease. Another one is diabetes who got severe infection from the phimosis, and he had to have debridement, and he stayed for 1 month in the hospital. The main investigation, of course, is PCR, and it has got high sensitivity and specificity. The main thing you should remember is take it from a skin lesion. If you can break a lesion and take it, great. Otherwise, just rub on the dry lesions and take. All the other areas, including blood and throat, have less yield. And in all cases, please screen both urine and blood for NAT, the nested PCR or the nucleic acid amplification test. Take wound culture, inform your patients, come back if there is too much pus coming out of the lesion, because we had a variety of bacteria. This is a biopsy done in the HIV case, and you can see the lesion that's protruding and those eosinophilic granules inside the keratinocytes. Our cases had overall good prognosis, and they heal in approximately 2 weeks. Complications noted are myocarditis, sepsis secondary to bacterial infection, and eye complication including loss of vision. So you need to be alert. What is new is fulminant mpox. It just means it's an accelerated disease in patients with CD4 count that is less than 100 or 200, or solid organ transplant patients, and they usually die from it. And when you start the ART in HIV patients, they go for iris, so, which also led to higher morbidity and mortality. So this is more interesting, I guess. So which is mpox and which is varicella? This is easy, this is easy. What do you do here? So I would say look for those annular pustules, which will give you a clue. Scabies and mpox, what I do is tell the emergency doctors, look at the scalp, look at the axilla. If the axilla is involved, it's mostly scabies. If the head is involved, it's mainly mpox. But you need to search for them. So in herpes, look for those annular pustules. When they coalesce together, look at the margin. If it is clear, most probably herpes. If it is a pustular scallop margin, it's most probably mpox. In herpes, it's mainly vesicles, whereas papillovesicles in mpox. In herpes genitalis, same thing. Look for the clear versus the pustular margin and annular pustules. If you are thinking of syphilis in your cases, the best place to look for would be the palms. So one has the fawn-shaped classical lesions that we know of, and the other one is, as I said, deep-seated pustules. Herpes zoster, if they call you, ask them if it's unilateral or bilateral, and that's going to give you the best clue. Going on to management, we don't have the drugs.
I think we are out of time.
Yeah. Okay, then I'll just go to
You have less than 1 minute. Just quick about the management. This is the most important.
Sure. The main thing is avoidance of spread and sexual abstinence for 21 days for the patient with till it scabs and falls off. But after that, 3 more months, he may be shedding the virus, so he should be informed about this. We don't have the vaccinations with us, so I will not go and say. In summary, I would say, consider mpox in healthy, sexually active adults who have the varicella-like or pustular genital rash. Always screen for other STDs because they may be coexisting. Consider secondary bacterial infection if there is a purulent discharge. Isolation for 3 weeks, and then sexual abstinence or using barriers for 3 months. In severe cases, the only thing that we have now is a trifluridine eye drops used for hepatic keratitis that can treat the eye involvement in mpox. The others are not available as yet. So the question is, who will adapt faster, man or virus? Thank you.
Thank you, Dr. Bakran. Yes. Please leave your question and the speaker will answer it through the app. We'll move to the next talk.
So let me welcome again Dr. Nicolas Dupin. He will present to us the role of doxycycline as a post-exposure prophylaxis in managing the surge of sexually transmitted infections. You can start.
Thank you so much. So I think it's quite rare that to reach a milestone in medical history. I think it's rare enough to reach a milestone with a chip to prevent disease. So I will go through the role of doxypep in managing the surge of STI. Let's come back 25 years ago when we achieved the treatment for HIV and showing that there is a decrease of the death linked to HIV by the increase of the protease inhibitors and what we call the HART. That was the first wave of the increase of STI because HIV was not anymore associated with systematic death. So we saw the first cases of syphilis, gonorrhea infection, LGV in the early 2000th century. Since 20 years now, we observe that there is still an increase of STI, and it's probably indirectly linked to what we call the prevention of HIV. There is a high degree of research on preventing HIV. There is no good vaccine for HIV, so there is other treatment for preventing HIV, such as TASP, treatment as prevention in those which are discordant couple, for example. It shows that it prevents 100% the contamination of the partner. And of course, the PrEP for HIV, which is very efficient in patients, in persons not using systematically the condom when they have sexual intercourse. So there is an increase of STIs, so we must think about how we can prevent this increase of bacterial STI. Just come back 50 years ago and look at this paper published in the New England Journal of Medicine in 1979. It was very interesting because these physicians, they want to see if prophylaxis against gonorrhea by minocycline can help to prevent gonorrhea. They have more than 1,000 Marines. They were in fast eastern port, and they have two groups. One, they give minocycline when they come back to the boat, and the other one, they give placebo. And they reduce the incidence of gonorrheal infection by 50%. So this is not new to prevent STD. It works with good efficiency 50 years ago. What we know now, we know that in target population, MSM, person living with HIV, transgender females, we know that doxypep, what is doxypep? Is to take 2 pills of 100 milligram between 24 hours and not more than 72 hours following condomless intercourse without exceeding 600 milligram per week. We have now 3 good studies, hypergay studies, doxypep in San Francisco, doxyvac in France, showing that this prevention with only 2 pills, taking 2 pills before 72 hours, was efficient to decrease by 80% the incidence of both chlamydial infection and syphilis infection. This is the slide from Jean-Michel Molina from doxyvac, hypergay, and you can see that there is a decrease of the chlamydia infection and syphilis, of chlamydial, of course, by nearly 86%, of syphilis by nearly 80%. It works, but a little bit less in gonorrheal infection, because you know there is a high degree of resistance to tetracycline of Neisseria gonorrhea. It decreased by 30%. Is it transferable to all population? This study was performed in female sex workers in Kenya, and in fact, it didn't work. What was the cause of the failure? The cause of the failure is a non-adherence to the treatment. They didn't take the pills. So you can't prevent the disease if you didn't take the pills. And how they show that they didn't take the pills? They measure in the hair sample the doxycycline in the hair sample, and you know that in the hair you can have the impregnation of the organism for more than 5 or 6 months. So you know if there is no treatment intake. So it's not easy. What are we learning? What are the questions? There is good, it prevents, but there is concern. Maybe doxypep, doxycycline, iterative, recurrent doxycycline intake could raise to antimicrobial resistance and have an impact on our microbiome. What was the benefit outside of clinical trials? What should providers' attitude towards doxypeps? And what are the eligibility criteria to take doxypep for preventing bacterial infection. What we are learning is that there is some papers showing that there is an increase of resistance of Neisseria gonorrhea to tetracycline, with a high increase, as you can see. This is the implementation in King County of the doxypep, and you can see there is a quite stable level of resistance to tetracycline and high level resistance to tetracycline, which increase very, very rapidly after the implementation of doxypep. As the doxy may have an impact on off-target bacteria, for example, Staphylococcus aureus or gas. Yes, it has. Yes, it has, and you can see in this slide, you can see that the incidence of tetracycline-resistant Staphylococcus aureus or tetracycline-resistant gas was more important in patients using doxypep in the last months in comparison to those not using doxypep. Again, on gonorrhea, this paper from Béatrice Berco from Paris, she thought it was a subset of the study of doxyvac. So she has looked for more than nearly 80 strains of gonorrhea. And what she showed that doxypep does not affect the susceptibility of gonorrhea to ceftriaxone, Cipro, or azithromycin. But she showed that for gonococcus, there is a high level, like Soje, a high level of tetracycline resistance. And the third thing is that there is a cluster that exhibits reduced sensitivity to cefixime, oral third-generation cephalosporin, and high-level tetracycline resistance. So the use of doxypep was associated with an increase in high-level tetracycline resistance and a reduced susceptibility to cefixime in gonococcus. So we must be vigilant and we must survey. Is the doxypep has an impact on the resistance to tetracycline of gut germ, gut bacteria, and on microbiome? Yes, this is a Nature Medicine paper published in 2024, showing that in patients taking doxypep, this is day 0, this is at 6 months, you have an increase of antimicrobial resistance to tetracycline in bacteria of the gut. So probably there is an incidence of the emergence of resistance to tetracycline in this population. What is the doxypep? It's working in trials. Is it working in the real life? This is reassurance. You can see this is from San Francisco, 3 different clinics that they have implemented doxypep to prevent bacterial infection. And in the 3 cohorts, you can see that there is a high decrease of chlamydia infection by 67%, 50%, 90%, and a high decrease of syphilis by 78%, 51%, 56%, and a very moderate effect on gonorrhea. This is other paper showing that after the implementation of doxypep, you have a high decrease of syphilis, a moderate decrease of gonorrhea, and a high decrease of chlamydia infection. So in implementation in real life, it works quite efficiently. How the healthcare professional appreciate the doxypep. This is a paper from San Francisco, and it was performed on 30 HCPs from 30 cities with a high STI high rate. 43% of these HCP have more than 100 MSM in their clinical panel, and 17% had previously prescribed doxypep. They express positive attitude towards doxypep. They are concerned, as I said, by antimicrobial resistance, which limit enthusiasm for some HCPs. They need additional data about the long-term safety of doxypep, and they ask for the development of guidelines. So come back to the guidelines, and we will see that the guidelines are quite heterogeneous. The AACS 23 guidelines recommend to propose to persons with repeated STIs on a case-by-case basis. The CDC proposed to give doxypep to those who have had an infection, STI, syphilis, chlamydial infection in the last year. In France, post-exposure treatment with doxycycline is therefore not recommended for the prevention of bacterial STI. However, the prescription may be considered as part of a shared decision-making process in a MSM and transgender women at high risk, those with more than 2 STI in the previous 12 months. We should interpret guidelines considering that mathematical model shown that limiting doxypep eligibility to people with multiple STI in the past year would be the most efficient approach. However, on the other hand, we have learned from HIV PrEP and from vaccine for monkeypox that limiting access to patients who meet more restrictive high-risk criteria can exacerbate stigma related to sexual behavior, sexual orientation, and gender identity. In summary, we now have sufficient evidence showing that doxypep is able to significantly reduce STI transmission among persons who are consistently using, not consistently using condom. It works on syphilis, it works on chlamydial infection, but we have still remains a challenge for prevention of gonorrheal infection. And in the Doxyvac paper by Molina, he showed that the vaccines against meningococc is not efficient to prevent and to diminish and to decrease a gonococcal infection. As doxypep moves into implementation, we should leverage the experience and lesson learned over a decade of implementing PrEP. Health care professionals, us, must support individuals to explore their needs and motivation and weigh the benefits, risks, and uncertainties about doxypep. The risk of AMR is real, and more studies are needed. Thank you for your attention.
Thank you, Doctor, for the nice presentation. Any question for Doctor? Okay, we'll move to the next talk by Dr. Suhail Al-Ahmed. Dr. Suhail will talk about oral mucosal lesions as the first signs of systemic disease. Welcome, Dr. Suhail. The floor is yours.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I would like to thank the organizers of this conference for inviting me to talk about this topic. I'll start by declaring that I have no conflict of interest whatsoever in relation to any content of this presentation. And I also would like to acknowledge the institutes where I worked and I'm currently working that allowed me to collect the cases that I'm going to present. And I'd like to point out that the clinical images shown in this presentation were consented upon by the patients who I have seen in the clinic. So when we talk about the oral manifestations, we are talking about part of the body that is quite unique, the mouth. It can manifest a lot of systemic diseases for a number of reasons, the first of which is the anatomical location. It is located at an intersection between the GIT, the skin, and the pulmonary systems. And all of those organs, they have diseases that can manifest in the mouth. The mouth, contrary to the skin, is known to have a significant amount of trauma and what is known as the Kubner's phenomenon because of the presence of the delicate mucosa and nearby the strong teeth with the sharp edges or the dental appliances. This results in a constant trauma to the mucosa that will unveil those diseases early before the skin. And we also have the heavy microbial presence. This eventually leads to a diversity of diseases that we see in the mouth. In general, statistically, we're talking about 1 in 10 individuals worldwide have some sort of an oral disease. We're not talking about the dental. We're not talking about the gum disease. We're talking about mucosal disease, 1 in 10 individuals. Most of those are white lesions followed by ulcers and inflammatory conditions. Usually it is known that diseases in the mouth are first to show and last to go because of the, like I said, the Kubner's phenomenon, because of the friction, because of the trauma, and because of the delicacy of the oral mucosa. So in order to cover the topic of today, which is the oral manifestations of systemic diseases, we need to break them down into different categories. So we'll start with the blistering disorders. And as you know, with the blistering disorders, we have the most common in children, which is the herpetic gingivostomatitis or the primary herpes infection. Of course, there will be multiple ulcers that are preceded by blisters in a child, and those individuals are going to be in pain. They will have all the constitutional symptoms. Now, on the other side of the screen, you will see a recurrent herpes infection. Now, remember, herpes is not only herpes labialis. It's not only the lip where it recurs. It can actually recur in the mouth, and usually the preferred site for the herpes virus is the keratinized mucosa, and that is in the gingiva and in the palate. What is really characteristic here is the unilaterality of that recurrence. It doesn't cross the midline at all because obviously the virus migrates through the trigeminal branch in its re-eruption. Other types of blisters are the autoimmune diseases, and this includes the pemphigus vulgaris, linear IgA disease, and mucous membrane pemphigoid. When it comes to pemphigus vulgaris, we need to initiate corticosteroids and monitor the electrolytes in order to prevent dehydration or imbalance in the electrolytes. We also need to monitor the antibodies against the antigen in case of pemphigus. When it comes to pemphigoid, it is much less severe than pemphigus. It doesn't affect the electrolyte balance. However, because of the fact that it also affects the conjunctiva, consultation by an ophthalmologist and initial topical corticosteroid treatment is necessary to prevent further scarring to that area. Of course, the diagnostic, the gold standard in the diagnosis in both cases is the direct immunofluorescence. Now, when we talk about the systemic diseases, we're not talking about the mucosa and the skin in case of the pemphigus vulgaris. If the case is diagnosed as suspicious of pemphigus vulgaris, if there is excessive painful oral erosions, lichenoid features in the histopathology, direct immunofluorescence is confusing. It's showing positivity in the antibodies intraepithelially and subepithelially, and there is an unexplainable lack of response to corticosteroids. You have to think about paraneoplastic pemphigus, and in this case, the patient needs to be screened for an internal malignancy. Now, moving on to the erosions and ulcerations in the oral mucosa, of course, the most common case of erosive ulcerative lesions that we see in the mouth from an immune dysregulation perspective is the oral lichen planus. It's a mucocutaneous localized disease. However, we always take into consideration the potential malignant transformation in those cases, usually in the erosive lichen planus, not the reticular lichen planus or the plaque-like lichen planus. A similar condition to lichen planus that has an impactful systemic implications is the lupus erythematosus. We also see atrophic mucosa. We see erosions. For some unknown reason, lupus tends to present in the mouth, in the palate, in the hard palate. Unlike the cases that we have seen in the lichen planus. So an erosive, widespread erosion in the palate that is not explainable, not reactive to any traumatic factors, and doesn't have the white striations or the Wickham striations that we see in lichen planus, associated with pancytopenia and skin rash, should alert the clinician to the possibility of systemic lupus erythematosus. Another common condition that we see frequently in the mouth is the aphthous ulcers. Of course, it's common. It is self-limited most of the time. It is annoying to painful, so some patients might need some form of topical corticosteroids to treat that. But in those cases, if the ulcers are also persistent, they're not going away, and the recurrence is very rapid. So, 2, 3 ulcers appear at the same time. When one heals, another 2 or 3 appear in another location. We have to take into consideration whether this patient has some form of nutritional deficiency. We have to take into consideration the possibility that this patient has Behçet disease, or celiac disease, or Crohn's disease. Usually with the Crohn's disease, the only difference is that the ulcer is going to be persistent in the same anatomical position and not widespread. But if we have multiple areas, bilateral, multiple ulcers that keep coming and going, we have to take into consideration the other possibilities. Now, color changes are also seen in the oral mucosa. And of course, the most common change that we see in the oral mucosa is white changes. And most of the time, those are reactive keratoses. Again, we're dealing with delicate, non-keratinized mucosa, nearby, immediately approximated to sharp edges of the teeth or the dental appliances. So frictional keratosis is always there. We always take that into consideration. However, there is a significant overlap with other conditions such as dysplastic changes or even squamous cell carcinoma. Clinically, they cannot be differentiated. For that reason, if the white changes are seen in a high-risk site and the patient has a high-risk profile in terms of risk factors, a biopsy would be necessary. We take the biopsy frequently in order to rule out the possibility that this is a case of SCC or dysplastic changes. We also have localized white changes such as some form of coated tongue due to dehydration, lichenoid changes on the dorsum of the tongue, and oral candidosis. But the only one that has a systemic impact is the oral candidosis or the pseudomembranous candidosis. If the patient has poor oral hygiene, the patient is on medications that can result in suppression of the immune response, or the patient has uncontrolled diabetes, we can explain the presence of pseudomembranous candidosis accordingly. But if those do not exist, then we have to do some proper workup for this patient because there is a possibility that this patient has some form of an internal immune suppression due to malignancy or due to HIV or due to other nutritional factors that we're not aware of. So those patients need to be worked up if there is no clear explanation for the fungal infection instead of treating the fungus immediately. Pigmented lesions are seen in dark-skinned individuals. We see some physiological pigmentation, which basically represents melanotic macules on the gingiva and on the mouth. But we have to take into consideration that if it is in children and if those pigmented lesions are discrete, sporadic, and they are seen perioral and perianal, the dermatologist will see that, then we have to consider the possibility of Peutz-Jeghers syndrome. And of course, the patient needs to be properly worked up for the Peutz-Jeghers syndrome in order to detect intestinal polyposis or cases of intussusception or some malignancy early on. Some pigmentation is not uniformly pigmented. We see a number of colors. We see some dark, black, black pigmentation or dark purple pigmentation. It's not uniform. Sometimes there are some bleeding spots. Sometimes there is some induration or elevation in some areas, and this represents melanoma. Melanoma in the mouth is extremely rare. If it occurs, it usually prefers the gingiva and the palate. But of course, the biopsy with the direct immunofluorescence, with in situ hybridization, immunohistochemistry is necessary to establish the diagnosis. Other causes of pigmentation, which are not localized but widespread, is the bronzing of the oral mucosa in general, bronzing of the skin, and this is seen in drug-induced and in Addison's disease. So that's another systemic implication of the oral pigmentation. Finally, we have the lumps and the swellings that can be seen in the mouth. So it depending on the history, depending on the exposure, history of exposure that this patient has had. It could be an allergic angioma if it's a swelling or edematous lips, but take into consideration that sometimes it is not only the lips, but also the gingiva, especially in cases of contact allergy to dentifrice, toothpaste, some sweets, lozenges, etc., that children commonly have. But if that swelling is persistent and is associated with surface erosion or ulceration or even angular cheilitis, then we have to take into consideration the possibility of granulomatous changes inside the connective tissue. If granuloma is detected, we need to do proper workup for the possibility of Crohn's disease, sarcoidosis, or foreign body reaction. But swellings of those situations are also seen in more serious conditions, such as lymphoma and leukemia. So a biopsy is necessary, and if the biopsy is not specific or doesn't show the disease, then a second biopsy or a good sampling should be performed in order to establish a diagnosis because of the possibility of more malignant diseases manifesting in the mouth. So a number of swellings can also be seen in the gingiva or around the gingiva or even on other parts of the soft tissue, such as pyogenic granuloma, peripheral giant cell granuloma, and squamous cell carcinoma. Pyogenic granuloma and SCC are localized diseases, but the one that has an implication with systemic conditions is peripheral giant cell granuloma. If this is diagnosed at the biopsy, then further assessment for the patient should take place in order to rule out hyperparathyroidism. Now, this is not the mucosa. This is swelling, still swelling in the head and neck area, and there are many causes of swelling in the head and neck area. But if we notice a swelling in the parotid area, the parotid gland, not the masseter. Masseter swelling can be secondary to grinding, to hypertrophy in the masseter gland, but a swelling in the parotid area, anatomically in the parotid area, associated with dry mouth and dry eyes, but most patients, they report the dry mouth because it is more relevant to them, should raise the possibility of Sjogren syndrome. Another interesting case that I wanted to finish up my presentation with is a patient who presents with a disturbance in the bite, is no longer able to bite as they used to bite in the past, associated with spacing between the teeth and hoarseness in the voice, in addition to some thickness in the skin and in the peripheries, should always be assessed for the possibility of acromegaly like this case. So this patient came, and the patient's main complaint was, I can no longer chew on my food because my teeth are not aligned anymore. And this was eventually diagnosed as a case of acromegaly. So in conclusion, oral mucosal diseases are prevalent in the community. Many of those oral mucosal diseases, they present a systematic disease, and the earliest manifestation of that systemic disease is actually in the mouth. And in many instances, the case is diagnosed in the mouth much earlier than the skin or much earlier than the GIT. With that, I complete my presentation, and I thank you for attending.
Thank you, Dr. Ahmed, for the excellent presentation. Any question from the audience, please, for Dr. Ahmed? Any question? So, Anyway, you can put your question in the app and Dr. Al-Ahmed will answer it at his convenience. Thank you very much, and thank you for the audience for attending the last session before the lunch. Thank you very much.